Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. This is fine. Thank you. Thank you very much, my dear friend, Professor Sofia Mubarika. Siap. So it's good to be back in Jakarta. The last time I visited Jakarta was many years ago, way before COVID. And it was totally different at that time, but this is my first visit to Yarsi University. So I must say that I'm very impressed with Yarsi University. My first impression was Yarsi University was a small place, but when I arrived, I was very surprised to see that, it's a huge place. In fact, it's bigger than my campus in Kota Baru, Kelantan. So I'm so happy to be here, and thank you for inviting me and also to share with you my experience. And I must admit that this is my first experience using Menti. So I have no experience using Menti, but this is also a new format for me, the way to teach in a workshop. But I like it, and I hope I will be able to use this in Malaysia and Menti. So I will be very quick. The organizers told me only 10 slides, but I have 25 slides. So, but I will be very quick. My topic is on thalassemia, it's not moving. Okay. So thalassemia is a form of hemoglobinopathies. So it's a group of inherited blood disorders and characterized by abnormal hemoglobin production. So the keyword here is inherited. And I think thalassemia, hemoglobinopathies can be found all over the world. And it has become a global health burden, also I think in this region, in Malaysia as well as in Indonesia. And the most common form of hemoglobinopathies are thalassemia and sickle cell disease. But today I will focus just on thalassemia because it is, I think, very common in Indonesia as well as in Malaysia. So like I mentioned earlier, thalassemia has become a global disease, especially it affects mainly the low and middle income countries. And I will show you later the reason why these countries, unfortunately, has been very much affected. So it is an inherited disease, and the mode of inheritance is autosomal recessive. And from the earlier slides, the earlier lectures we heard this morning, I think it's quite easy to diagnose autosomal recessive disorders. So when you see, you just need to identify the carriers, and then, if the disease appears to affect just one generation and affects both male and female, I think most likely it will be an autosomal recessive disease. So thalassemia affects regions or countries where malaria is endemic. So the reason for this is in regions where malaria is endemic, the people there will try to evolve so that they can fight the malaria infection. And as we know, the malaria parasite injected by the mosquito, it will invade the patient's bloodstream and goes and multiply in the red blood cell. So without a good red blood cell, it will not be able to multiply. So in order to survive, man changes their red blood cell to make it fragile, so that the malaria parasite will not be able to grow within the red blood cell. So this has saved them from malaria. However, it has created a new disease, the hemoglobinopathies and thalassemia. So if you see the region where malaria is common, those are the same region where thalassemia and hemoglobinopathies are also common. And unfortunately, these are also the region where the low and middle income countries are located at. So to treat thalassemia, it costs a lot of money, but unfortunately, if it affects low and middle income country or low income country, the cost for the government is huge. So thalassemia patients in these countries tend to suffer. They do not get optimal care because most of the budget or the funding will go to other diseases, but not to thalassemia. So basically, thalassemia can be divided into alpha and beta depending on the chain, the beta chain or the alpha chain of the hemoglobin, which one is affected. So for the alpha thalassemia, it affects mainly the alpha 1 and alpha 2 genes, which is located on chromosome 16. And for beta thalassemia, it affects the beta globin gene, or the HBB, which is located in chromosome 11. So how thalassemia is inherited, I think this is obvious. I think most of you are genetic counselors, you are well aware of this. Alpha thalassemia can be divided into the one gene deletion, which is called the silent carrier. And those individuals affected by a single gene disorder or single gene alpha thalassemia tends to, the offspring, 50% of the offspring tends to be, affected or become a carrier as well. And the other 50% are normal. However, with remaining 3 functioning alpha gene, it causes no symptom because this is sufficient, to provide, to live up to the needs of the requirement for the patient. Now, if there's a 2 gene deletion, the risk to the offspring, will increase, and it will affect. All the offspring, where all of them will be carrier. And this is called alpha thalassemia trait. And for 3 gene deletion, which is called hemoglobin H, the offspring tend to be affected either by a single gene deletion or a double gene deletion or 2 gene deletion. And of course, alpha thalassemia major or 4 gene deletion is fatal, and most of the time it results in death of the baby or hydrops fetalis. So what we need to remember is how this one gene, 2 gene, or 3 gene, or 4 gene deletion affects clinically. As I mentioned earlier, 1 gene deletion, basically the patient is normal, not affected at all. And 2 gene deletion, the patient tends to have just mild anemia. 3 gene deletion, they tend to have a moderate anemia, and sometimes it can lead to severe anemia and maybe blood transfusion dependent. And 4 gene deletion is fatal. But for beta thalassemia, I think it's more straightforward. You can either have 1 copy of the gene being mutated, and the other copy normal, and of course the risk to the offspring would be just 50% being a carrier. And of course, if you have 2 copies of the gene affected, it can either result in moderate to severe anemia. If it is just moderate anemia, we call that thalassemia intermedia, clinically thalassemia intermedia. And if it is severe, we call that thalassemia major. So how do we diagnose thalassemia? So it's important that all patients get, first as a first line, the hematological test. Also, the second line would be the molecular test, which is considered in many instances to be confirmatory. Now, hematological investigations include a full blood count or full blood picture, HB analysis, and HBH inclusion test for the alpha thalassemia. And of course, the confirmatory test is molecular study. So basically, the primary hematological test, as I mentioned earlier, would look, we have to do a full blood picture and look for the MCV and MCH value. From there, we can proceed with HB electrophoresis or HB analysis once we have ruled out iron deficiency anemia. And some of the form of thalassemia, beta thalassemia, and alpha thalassemia especially, would be required to do a molecular analysis. So in most hospitals, you see that for the diagnosis of thalassemia, two labs will be involved, the hematology lab and also the genetic lab. But some centers which are more established, which have a thalassemia center, they tend to have a combined lab, both hematology as well as a genetic laboratory. And in fact, I think in many countries now, most of the hematology lab would also have a molecular unit within their hematology lab. So when to proceed for a molecular test? Those are, the situations listed there. But I'd just like to highlight about prenatal diagnosis as well as genetic counseling, where I think molecular tests or molecular information of the patient is necessary to provide an effective genetic counseling as well as prenatal diagnosis. So I will not go into detail regarding the tests that we can do for the beta thalassemia as well as alpha thalassemia, but I would just like to mention about the common tests that we do to diagnose beta thalassemia in Malaysia and also believe in Indonesia. And for alpha thalassemia, the GAP PCR. And for beta thalassemia is the MAMS PCR, or the multiplex amplification PCR. So MAMS PCR is used by most hospitals in Malaysia to diagnose beta thalassemia. So it involves 5 different multiplex arm PCR panel plus 1 single arms PCR reaction. So in total, there's 6 panels as listed there. And they are able to detect, from these 6 different panels, they are able to detect a total of 20 mutations. So these are the list of mutation which are most common in Malaysia. And I believe, as I've spoken earlier to the colleagues from Cirebon, is also among the mutation which are also common in Indonesia. So I think MAMS PCR is relatively cheap, most of the labs, the genetics lab in many hospitals will be able to carry out this test. And of course, I think now there are also newer tests, including those using the NGS panel sequencing. But I won't go into detail for that in view of time. This is my last slide. So I'd just like to mention about for alpha thalassemia, one of the the primary tests that is being used is the GAP PCR, where this is a rapid, a simple, and non-radioactive method that allows the identification of the large deletion that we see in alpha thalassemia. So this is also, I think, most of the genetics lab will be able to use GAP PCR for the diagnosis of alpha thalassemia. So these are the 2, I think, primary tests which can be done in many genetics labs and help to diagnose thalassemia. So I think that's my last slide. Thank you very much. And I'd just like to add that thalassemia being common in Southeast Asia, especially Malaysia, Indonesia, I think deserve more attention than what it has received by now. More attention by everyone, especially the government, the policymakers. Thank you very much.
Very much. Any more questions?
Can I add?
Okay, Prof. Sivalil, please.
Thank you. Yes, I would like to add to what Professor Naraza has said. I think that's a very good question. I think, in fact, this is a good example of a condition where it should be reported, because this is something which I'm sure every one of us would want to know if we have such a mutation. As Prof. Naraza mentioned, it's not every day that the patient will get hemolysis, but at any time that he or she can be exposed to any of the triggering factor, including drugs. There are drugs in which this XPD patient needs to avoid. So these are the drugs that they need to know, and they need to inform their doctors. So I think this is a good example of where a whole genome sequencing is important in order to prevent or to avoid situations like this from occurring in the future. We are talking about the future. So this, in fact, to me, this is a very good example, and I think this should be reported. Thank you.
Thank you.
Yeah, okay. Prof. Valil, this is the quiz for you. Could you explain a little bit about this results?
Okay.
Yeah.
A is false. I think I mentioned earlier, this is very obvious. I think the answer is autosomal recessive. And B, molecular testing, I think this is a bit controversial. So it depends. So 29% answered true, I think. That's true, right? It's true. So it can be true, it can be false. So depending again, you can argue about the answer. It can be true because, when you do molecular diagnosis, that's the, it's proof that the patient carries the mutation and the patient has the disease. So it's true. However, in many countries, this is not being done. Molecular testing is not being done as a primary test. And most of the cases can be diagnosed by just using hematological tests, a full blood picture followed by HB analysis. So it can be true, it can be false. So both answers are okay. So I would say that if this is an undergraduate, this is a test for undergraduate students. If the student answer false, I can accept that. But if this is a test for postgraduate students in hematology, perhaps I would not accept that answer. So C, thalassemia affects individual in malaria endemic area. I think this is true, as I mentioned in my lecture. So those two are very related, malaria and thalassemia, the evolution of thalassemia. And thalassemia is most common in high-income countries. This is false because primarily, it occurs in low and middle-income countries, as I explained earlier. But due to migration, it can also now higher-income countries have a lot of thalassemia and sickle cell disease. So because of migration, for example, in America, primarily there was no sickle cell disease or thalassemia, but due to migration from people from Africa and also from South Asia, now you see a lot of cases of sickle cell disease, thalassemia, not just in America, but also in Europe because of migration. And I think that's one more E. Can you go below? E, A, B, C, D, and E. Yes. So thalassemia is characterized by abnormal hemoglobin production. I think this is true. I think this is a straightforward answer. So the problem is with the abnormality in the production of hemoglobin because it can be either in the alpha or the beta chain. And this is due to the mutation of the gene. So I think this is quite straightforward. There's another question by me. Okay, so diagnostic tool for thalassemia, karyotyping, I think this is false. You cannot identify by karyotyping the mutation in the beta globin gene or the alpha globin gene. So you have to do a molecular test. No karyotyping, so it's false. Fish also, I think is false. I do not think there's any fish probe for the HBB gene or the alpha gene, as far as I'm aware, unless there is a probe, to detect, a deletion in the alpha gene. Then you can use fish, but generally no, it's false. And mom's PCR, yes, that's true. I think that's, as I mentioned in my lecture, that's the most common test. You are the primary test used in many countries, Malaysia, and I believe also maybe in Indonesia as well. Simple test, multiplex test. And full blood picture, yes, I think this is a primary test. It can be done in many hospitals in Malaysia, even the small clinic in the rural healthcare center, they can do a full blood count or full blood picture. And then capillary electrophoresis, I think this is true. This is without a molecular diagnosis, you are able to diagnose thalassemia by using a CE, especially for HBE. I think Dr. Iriani mentioned in Indonesia, you say it, HBE. HBE, HBE. So I think those are my questions. Yes. Thank you. Any question? I'm happy to answer. Prof. Sophia from Mubarak.
If there is some questions for Professor Zulfalil.
So
Yep.
what I want to ask is whether we should do newborn screening and what kind of tests do we need to do? What should we test for newborns screening, and what can be done with molecular tests for newborn screening? Thank you.
Thank you very much. I think that's an very excellent question. In fact, I like that question very much. I wanted to put in my slide, my last slide normally, but I thought that it's not proper, and I think our friends from 3 billion would also love me for saying this. But what I want to say is the future is in genomic screening. So as a geneticist, I strongly believe that we should do genomic screening for everyone. So also in most of my lecture, in my last slide, I usually I will write genomics for all, leaving no one behind. So we need to do, all of us, we need to do a genomic screening for ourselves so that we can determine our future. We can at least predict what our future. Of course, the final decision what will happen to us in the future is from God, from Allah. But from our DNA, we will be able to gather a lot of information what is going to happen to us in the future, especially for diseases. And I think as doctors, any healthcare personnel would want to know this, and we want to prevent this from happening. So I think that's the future. That's the way forward. We have seen Genomics England. They have started a pilot program a few months back to screen newborn, to do newborn genomic screening for newborn. So, of course, there will be a lot of challenges, for this pilot project. The outcome may be favorable, may not be favorable, but I think they have already shown that, at least there is, they're willing to try out whether this is the way forward by screening our newborn. If our newborn know their DNA, their genomics profile, I'm sure in the future we will gather more information about what will happen, to them, to any mutation or any variants that we see in our genome. Someone mentioned about VUS. Of course, there are many VUS now, but remember, today it may be a VUS, next week it may be pathogenic, or it may be benign. So things are evolving, and they are evolving as we speak in real time. And I think we will see a lot of improvement in genomics. And that will be a time where I think genomic screening will be routine. So I strongly believe our newborn deserve to have a genomic profile. So genomics is the way forward. So, if screening, we are now doing newborn screening, but we are not doing genomic screening. We are doing, targeted testing, diseases which are common to the population, diseases which can be, which have treatment. So all these criteria, mainly because it's expensive to do genomic screening, but, if we have the means, why not? Do just genomic screening, and just learn and have the information, have a genomics profile. And someone asked me, how will you store, the large data that are generated from your genome profile? So I think we should discuss of ways, in storing the data. Someone mentioned in Malaysia, we have identity card, we have a chip in our identity card. And even now, as we drive a car, we need to pay the toll. We can pay in Malaysia. You can use your identity card, and top up with some money. You can pay using your identity card. So why not store our genomics profile in our identity card? So that's one of something that which we can think about. So as a geneticist, I strongly believe in genomic screening. And yes, you are free to say that you do not agree with me.
No, no. No, it's not that I'm not agree. I think that by what you said is that not only newborn but even us have to do the screening. Maybe we still have some disease that we have never encountered before in our
Yeah.
life. Yeah.
Yeah, some diseases appear much later in life. You know, as older, Alzheimer's, for example. You know, so why not? You know, if you have the means, why not you do a genomic profile and look, you know, for any of these variants. Yeah. So I can see the 3 billion guys are agreeing with me. So, you know,
Thank you, Professor. Naraza would like to. One more question. Okay. Okay. Should we stop the, or just we leave it? Oh.
Thank you for the opportunity. My name is Vanessa. I have a question for Prof. Alwi. How's the regulation in Malaysia in controlling thalassemia? As we know, some country, they have some regulation like before a couple get married, they have to test for thalassemia. And if both of them don't have or didn't carry any trait, so they can get married. Because in Indonesia, I think we still it's still hard to detect thalassemia in couples. Thank you.
this is again a very great question. Thank you so much. So back to the same question that was asked earlier about newborn genomic screening. So if we can do a genomic screening for our newborn, you know, we will be able to tell whether that baby will develop thalassemia or not, or whether that baby will be a thalassemia carrier or not. So based on that, if we have a genome profile, all of us, if we have a genome profile, we will be able to identify whether you are a carrier or not, whether your future husband is a carrier or not. So the key is still in having a newborn genomic screening, a genomics profile for the newborn. You can also, you know, from there you can detect whether you know, that baby or that individual is a carrier for thalassemia or not. In Malaysia, couples who are getting married, they are encouraged to do thalassemia screening. HIV screening is compulsory for any couples getting married in Malaysia. But thalassemia screening, you know, they are just being encouraged. And I think the government, there has been recommendation to make all married couples getting married to undergo thalassemia screening, but the government has decided not to make it mandatory. So I am not aware. I'm not sure what is the reason, what is the decision. However, the government have decided. You know, there's three times, basically three age group which you can screen: premarital, and also newborn, and also what the government has decided is to screen the secondary school students, 16-year-old secondary school students, for thalassemia. So the program, screening program, has started in 2016. So that's about 8 years ago. And already, I think more than 1 million Malaysian secondary school students have been screened for thalassemia. So there are, but again, this is not compulsory. You know, the team of nurses will go to the school, all the schools, to screen. But the parents, they have a right to refuse the screening. So even though the screening, you know, is not 100%, but most of the students have been screened, you know, and many carriers have been identified. And I think these are the students who are going to leave school at the age of 18 years, and they may get married when they leave. You know, they may start working and they may get married. So it's almost, you know, you can say as like a premarital screening. And I think it's acceptable. It has been accepted by the Malaysian community, the public. But still, if you ask me, newborn screening is the way forward. Yeah.
Thank you so much.
Yeah, it seems still so many questions will be arise. Uh, According to the committee, because this topic is so interesting, so I would like to open one more discussion. So please raise your hand if there is some questions still. Okay, one, another questions? Yeah.
Thank you. My name is Noreen, and I would like to ask question to Prof. Silvalio. Prof, how about the ethical aspect in the genomic newborn screening? When will we deliver the information to the parents maybe, or do we need to wait the baby until get some get adolescence or maybe adulty? How is your opinion about this?
Okay, thank you again. This is a great question. Now I know why Prof. Sultana likes you very much. She said you are her best student. So only good student, best students, they ask good questions like this. To be honest, I do not have an answer. So I think this is one of the biggest challenge in doing a newborn genomic screening. And I think this issue has also been acknowledged by Genomics England. So when they started the pilot project for the genomics newborn screening, this was among the major issues that they say that they will face, and we are hoping that as a result of the pilot project, we would be able to have some answers or some recommendations to address those issues. So, like I said, to be honest, I do not have an answer for that. We can continue discussing, but as mentioned by Dr. Ahmad, we may not just Maghrib, we will not finish by Maghrib, maybe by Isha as well. So, so it's a good issue, but I do not have, an exact answer. And I do not think that there is a one single right answer as well. Yeah.
Thank you. So I want to continue this discussion up to the ethical and legal perspective. Yeah. So I heard in developing countries like US or Australia that people doing genetic testing, like you said, we can screen ourselves. Then when we get the results, it is connected to health system, that the insurance won't pay you if you get the disease that is existed in your genetic as part of genetic disease. So first question would be, what about in Malaysia? Just for sharing, maybe if you have information about it. And the second and maybe the hardest question would be, what do you think about it? Because I think it's not fair. It's for, maybe in Indonesia we can do screening because it's not connected yet. So I told my patient, if you got this disease, then you better buy insurance before it happens, right? but if it is connected to the health system, then it's not fair. You know that you have that risk, and the insurance won't pay you. It just doesn't seem fair. Thank you.
Okay, again, very good question. So 2 weeks ago, WHO, I'm a member of the WHO. They have formed last year. They have formed what they call the Technical Advisory Group on Genomics, the TACG. So this is following COVID pandemic, where during the COVID pandemic, they notice that many countries do not even have a proper genomics or genetics facilities or a capacity to diagnose, to do the profiling of the virus, the COVID virus. So there's a big, huge gap between the high-income countries where they have, the cutting-edge genomics lab, and the low-income countries which doesn't even have a genetics lab which can do a PCR for the COVID virus. So because of this, WHO has identified genomic as a very important area for healthcare, for the world. And the aim is to narrow the gap between the higher income country and the low income country. So one of the issue that we discussed 2 weeks ago when we had a meeting was how to tackle this issue. The ethical issue as well as the insurance issue. So by doing a genomic profiling, we know that there are a lot of advantages, especially in healthcare and disease prevention. But the pitfall is for to get insurance, as you mentioned. So there is no answer at the moment. There must be a discussion on how to go around this issue with the people, the stakeholders, the government, the policymaker, as well as the companies, the insurance companies. There should be some guidelines, in fact, legislation in place before we can safely say that all the interests of everyone is taken care of. Everyone, including us, the patients, the public, the community. So without any legislation in place, you are right. This patient will be at a disadvantage, and they will not agree to do genomic testing. So that is sad because it will be a step backwards in terms of healthcare. So the progress must be in line, as you mentioned, with legislation safeguarding the interests of patients as well as the community, the public. So at the moment, you're right. Even in Malaysia, we do not have any legislation. I think it's still a big issue. But I think it is not easy, because everybody has their own interests, especially, those insurance companies. They will also try to safeguard their interests. But I'm sure as genomics is becoming more routine, it will be in the mainstream practice for medicine. Then I think whether they like it or not, they have to, to adjust themselves, to fit in the progress. So the government needs to play a big role as well. The government of the country, the policymakers. So I don't know whether I've given a good answer.
Would also like to remind everybody to stay in your seat because we will announce 3 best participants for this workshop. Let's give a round of applause for our speakers. And next, I would like to invite Pak Ahmad to give a closing speech. And also announce the 3 best participants from this workshop.
Bismillahirrahmanirrahim. So, all good things apparently have to got to the end. We wish we can go proceed until subuh maybe, but apparently that's not possible. First of all, we'd like to thank all of you, to thank all the participants in this first day of the workshop and symposium series. It's been done, it's quite interesting, yeah, the topics, and the last one, it seems everybody's very engaged and we appreciate. So we would like to congratulate all of you, all the participants, to get involved in how to, understand the complexity of this disease, genetics, the counseling, and also the testing. So, this time for us to actually announce the top 3 best participants when they can actually respond to the question. Okay. So I guess I'll start with the third place. Is Mega Hayati from Universitas Yarsi. Okay. Stay first. We'll call you together. Okay. And then the second place is Dr. Tiar M. Pratamawati, Biomed from Universitas Gunung Jati. And the last one. And not the last one, the first place. Okay, ready? From Universitas Pertahanan, Dr. Venti Mulyanasari. Okay, for all these three winners, please come to the front to receive our appreciation from Prof. Sultana.